بسم الله الرحمن الرحيم. في الأول أنا أحب أشكر طبعا الأستاذ الدكتور ماهر فؤاد على دعوتي إن أنا أبقى موجودة معاكم في المؤتمر، وبشكر اللجنة المنظمة برئاسة الدكتور عمرو حسين على الأورجنايزيشن الرائع. الحقيقة الدكتور ماهر لما كلمني قال لي قدم لنا حاجة، فأنا اخترت إن أنا أقدم كيس من حالاتنا وأقول عليها شورت كومنت. Our case, a female child, Hannah. She was born in الغربية at June 2010. She is the fourth child of a consanguineous marriage. She has an older, healthy sister and a younger one. There is a history of neonatal death of a twin with previous 3 abortions. The patient presented to Tampa University at the age of 2 years by a picture of AKI. So she presented with urea, hypertension, volume overload, and renal impairment, together with anemia. She gave a history of recurrent attacks of puffiness of the eyelid during the last year before this attack, and it was associated with gastroenteritis. She underwent acute peritoneal dialysis and received blood transfusion. At that time, she had microcytic hypochromic anemia with hemoglobin 8.9 gram per cent. Platelets and total leukocytic counts were within normal. Kidney function, BUN 68 milligram per cent, serum creatinine of 4.5 milligram per cent, and urine analysis showed albuminuria 1+, fast cells 8 to 10, and RBCs more than 100 per high power few. The complement study was normal. Abdominal ultrasound showed bilateral normal sized kidneys with grade 2 echogenicity, no back pressure, stones or cysts. The renal impairment persists for about 3 weeks with GFR less than 10 milliliter per 1.73 square meters surface area, and so biopsy was done. It was done in Mansoura and showed thrombotic microangiopathy, and there was a suggestion for malignant hypertension or hemolytic uremic syndrome. Here, the glomerulus showed thickening of the capillary basement membrane with duplication, with some interstitial fibrosis, mild interstitial fibrosis, and thickening of the arteriolar wall with some fibrinoid degeneration. After this biopsy result, the patient was referred to Abu-Rish Hospital for regular dialysis and plasma exchange. As the patient showed no improvement after 5 sessions of plasma exchange, rebiopsy was done. And it revealed almost the same picture with duplication, segmental maculation, and moderate mesangial matrix expansion. However, some arterioles also showed onion skin appearance with red cell fragmentation and endothelial swelling and endotheliitis, and changes in the interstitiums showed increasing of the fibrosis with mild to moderate fibrosis. This picture is compatible with thrombotic microangiopathy with acute interstitial nephritis passing into chronic stage. According to this diagnosis, we did a genetic study which revealed anti-factor H antibody was negative, ADAM13 had normal activity. Further 5 sessions of plasma exchange were performed with no improvement, and the patient was scheduled for regular dialysis treatment. We did left brachiocephalic fistula, and unfortunately on the first day of dialysis tried to use fistula with the first puncture. The patient developed an attack of convulsions with deterioration of level of consciousness and left hemiplegia, every fistula thrombosed, and the patient was put on peritoneal dialysis. CT brain was done and revealed extensive brain infarction on the right side. Coagulation profile showed prothrombin time normal, INR normal, and lupus anticoagulants and anticardiolipin IgM screening showed positive results. ANCA, anti-nuclear antibodies, anti-double strand DNA were negative with consumption of C3 and C4. So we put the diagnosis of antiphospholipid syndrome with secondary TMA. The patient started intravenous heparin with pulse steroid and IVIG. Oral anticoagulation started, warfarin, anti-malaria, like meal. The child gradually improved, and apelmicase was inserted for regular dialysis treatment. This is a follow-up CT with improvement of the brain infarction. Then the patient was scheduled for transplantation. Both parents showed different blood groups, not matching, and the father provided one of his friend emotionally devoted unrelated donor, and we prepared for transplantation. This is the pre-transplant labs, lymphocyte cross-match negative, pan-reactive antibody 10%. During the preparation, we defined bilateral grade 4 molecular direct reflux, for which we did left nasal nephrectomy 3 weeks before the operation. The operation of transplantation was started on May 2014. At that time, the patient was 4 years old and her weight was 12 kilograms. Right naked recipient nephrectomy done intraoperative. She received ATG infection. The ischemia time was 55 minutes. Intraoperative heparin was infused, and immediate dialysis, most post-operative course was established. The patient had excellent graft function with decline of serum creatinine to 0.4 mg/% by day 3. She had normal graft echogenicity and differentiation with no back pressure changes. And the initial doctor showed adequate graft arterial supply and venous return with the resistivity index of 0.7, and she was discharged at day 12 with serum creatinine 0.4 mg/dL. She was on steroids 20 mg per day, cyclosporin 125 mg per day with a trough level of 220 nanogram per deciliter, and myfortic 540 mg per day. Her antihypertensive medication, she was on warfarin 1 mg per day, and prophylaxis against CMV, Valdan, cyclovir, 450 mg every other day for 3 months. This is our patient, Anna. And the current condition, 8 months after transplantation, with stable graft function. Here we can see that in any case of TMA, this is a pathological diagnosis. We have several causes. First is the HUS-related diarrhea, D-positive HUS, caused by Shiga toxin. We have atypical HUS and TTP. Atypical HUS complement disorders as factor H and factor I deficiency, and TTP atom 13 deficiency. TMA also can be caused by vasculitis related to autoimmune conditions as systemic mucositis and antiphospholipid syndrome. It may be caused by drugs pregnancy, hypertension, post-cardiac surgery, malignancy and radiation, post-transplantation in relation to drugs also or rejection, DFC and coagulopathy. So these are the causes and the underlying pathogenesis of TMA. Here is the recurrence risk of different forms of TMA after renal transplantation. For the diarrhea-positive HUS, it has negligible risk of recurrence. For diarrhea-negative HUS, we have mutation in factor H, mutation in factor R, and also Adams 13 deficiency. This carries very high risk, might reach up to 100%. Mutation in membrane cofactor protein, no risk of recurrence. Idiopathic causes, risk up to 55%. And in cases secondary to pregnancy, drugs, autoimmune conditions, has negligible percent of risk of recurrence. An important point to be looked for is that in cases of antiphosphorated syndrome, we have a possibility reaching up to 60% that the patient post-transplantation might develop anti-endothelial cell responses, and so we have to reach for this in such patients. Take-home message. For a case of diagnosed as TMA pathologically, it might be, especially in children, a case of HUS positive diarrhea, and this condition has no risk of recurrence, though most of these children usually resort and do not reach end stage renal. However, in diarrhea-negative TMA, we have to look for Adams 13 activity, complement gene defects as factor H and factor I. For this condition, recurrence risk, as we mentioned before, is very high. So we have to do either extensive perioperative plasma exchange with exogenous administration, and this is a very expensive long protocol. We might do combined liver kidney transplantation. وانا بعد الدكتور خالد يبقى يساعدنا في الموضوع ان شاء الله. Membrane cofactor protein mutation has no risk of recurrence. If we excluded both these conditions, we have to search for an underlying cause for the ATM. For TMA, it might be secondary TMA as our case, which has no high risk for recurrence, but it needs a specific treatment. And for idiopathic TMA, it has also a high risk of recurrence reaching up to 60%, so we have to be very cautious in such cases. Thank you very much.
And thank you, Professor Dr. Fatina. The floor is open for discussion. Yes.
الحاجه الاولانيه استعمال الاي دي او جي في الفرش على اساس ان كان عندنا سيلر كيس وكانوا النيورولوجي عندنا معترضين جدا عشان موضوع البروستامباتيك افكت بتاعه. الحاجه الثانيه لاحظت حضرتك عاملين البلاد جروبنج سب جروبنج. برضه احنا كونفرونتد بالقصه دي عندنا وبحثناها اكستنسفلي، فهل انتوا بتعملوا سب جروبنج؟
بنعمل سب جروبنج ريجولر لاي بلاد جروب ايه؟
ما هو يعني في الحاله لو قابلكم مثلا حاله الريسيبيانت اي بي والدونر اي وطلع اي 2
الريسيبيانت اي 2 والدونر اي 1 لا.
احنا كان عندنا حاله سيم الحقيقه، ويعني عملنا كانت ديبيتبل جدا، وفي الاخر يعني برضه خدنا راي بروفيسور اوبنز وكان بيقول ان مفيش اي ديفرنس والسب جروبنج ملوش اي قيمه. ف
allowed ان الريسيبيانت يبقى ايه ويريسيف فروم اي 2
بيقول ان هو يعني theoretically رايت جاب بقى الداتا، يعني رد علينا رد يعني طويل، واحنا دلوقتي بنحاول ندرس القصه دي عندنا.
طب انتوا لحد دلوقتي بتعملوا ايه؟
احنا الحقيقه في فتره يعني فتره طويله ما كناش بنعمل خالص سب جروبنج، وبعدين جت في فتره عملنا السب جروبنج وبدانا بقى نواجه المشكله دي. ورجعنا لقينا نفسنا زرعنا الناس كانوا الريسيبيانت A2 والدونر A1. فبدانا دلوقتي نجمع بقى الداتا نشوف، بس الداتا بتاعت يعني CTS بتقول ان مفيش اي ديفرنس خالص. طيب
If you allow me to respond to your 2 points, if you are going to transplant A1 to A2, you are dealing with ABO incompatible transplantation. The acceptable precautions بتاعتها, but not for the traditional transplantation. You need to give induction therapy. You need to have very close monitoring لل de novo HLA or de novo donor-specific antibody response. If you are going to do these precautions, you are dealing with ABO incompatible transplantation, which is non-acceptable. And I know that in Mansoura you give induction therapy to all your patients. I would consider this a bit waste of money if you are going to give induction for all patients and in such a poor country as Egypt. لما انتوا عندكم فلوس كتير ربنا يبارك لكم. ده الكونسيبت بتاع الاي 1 والاي 2.
معلش قبل ما نقل اللي حضرتك بتقوله ده كان بالظبط الثيوريتيكال بيزس اللي احنا كنا واقفين عنده، ان ده اي بي او انكومباتيبيليتي، بس الداتا ما بتقولش كده خالص خالص، يعني بتقول عكس كده.
لا الداتا والجينيتيك اناليسيس اوف ذا اي 1 والاي 2 ار established, they are different. والاي 1 is broader genetic expression than A2. دي established، ده احنا مش هنقدر نجادل فيها. الاوتكم بقى you are dealing with ABO incompatible transplantation، ده الفاكت. البريكوشنز اللي بتعملها وتطلع جود اوتكم، احنا لسه متكلمين على الاي ABO incompatible بالبريكوشنز you get almost near results، انما ما تزرعش من غير البريكوشنز. الكونسبت ده of giving IVIG for such a patient ده البروتوكول الانتي فوسفوليبيد، يعني يو كانت باي باس. يعني هو معروف الانتي فوسفوليبيد اللي هو معروف ان هو بيجي له الثرومبوتيك تندنسز، one of the parameters of the treatment is IVIG.
الحقيقه حضرتك جاوبت يعني كده عايش سنتر فاتيك.
معلش اتفضل.
Thank you, Dr. Fatina. I will comment first on Dr. Gamal Saadi. We are using induction therapy for all our patients, but
and we use this also in pediatric children.
But we have the rationale in randomization studies and research to minimize the immunosuppression. Sometimes our patients on just monotherapy or double therapy to avoid steroid use. This is the rationale for using induction therapy in our patients. My question for you. Regarding this case, of course, we are lucky to manage such a case, and we can find a cause for this thrombotic microangiopathy. And I observed that you requested this antiphospholipid syndrome investigations in the second biopsy, not from the start. This is number one. Number two, if you imagine that these investigations were negative, how can you proceed for transplanting such a girl?
So actually, we did the investigation for antiphospholipid after the attack of brain infarctions, which is not regular finding in a case of HUS in our patients, young patients. So when this happened, we started to find a cause, and that HUS is secondary to an underlying disease, which we already found. For a case of HUS, either it's diarrhea related or non-diarrhea related. If it is non-diarrhea, it's atypical HUS, we have to do the gene study, which were already done in our case. We did the ADAM13 and factor H antibody, and they were found to be negative. If we didn't reach the diagnosis of antiphospholipid antibody in presence of this genetic study, we would do the transplantation.
Is it common to find the consumed component in antiphospholipid syndrome?
It's not present in all cases, the consumption. However, it's common to be found in atypical cases of HUS.
We have here just complement factor. You did H.
We did H and we did other protein.
I and membrane cofactor protein.
No. We didn't membrane cofactor. However, membrane cofactor protein has no risk of recurrence.
But still the diarrhea related thrombotic microangiopathy. Still, we can have some cases with atypical hemolytic uremic syndrome with
Yes, of course.
diarrhea.
The presence of diarrhea does not exclude the possibility of atypical HS.
Thank you.
Okay, thank you everybody, and the session is closed.